Good afternoon or good morning, depending which time zone you're in, and welcome to this first of three set webinars that we're holding under the Economics of Healthy Aging program. This program is trying to take a dispassionate and thoughtful look at what are the challenges that come from population aging in terms of financing and delivery of health systems, and how we can take best advantage of the demographic changes and the opportunities that they bring. Policymakers are often worried about the effects of population aging, and obviously there are challenges that come from this. But on the other hand, there are many opportunities, and many of the challenges can be managed if we have a good understanding of the issues and if we take appropriate policy measures. There are obviously issues around changes in the labor market, changes in employment patterns, and changes in tax revenues and other sources of funding that could be available to the health system. But what we're trying to do here is to look at each of these issues and shed some light on both what the real nature of these problems might be, but also how policy responses might usefully be brought to bear on these challenges. We've assembled for today a very strong team. I'll be introducing them as they join the webinar. But first, I'll be handing over to the coordinator of the London hub of the Observatory, John Silas, who will be giving us an overview of the issues. Over to you then, John.
So concerns about health financing in the context of population aging are driven by a number of myths, and we're going to talk about some of these myths today. So focusing on the revenue side and where the money comes from, one of the big myths is that population aging is associated with a worse economy. So as the population ages, there's many people who believe that the economy will slow, the growth will slow, the economy will shrink for a number of reasons. For one, there's an expectation that older people are less economically productive than younger people, and this is driven by studies that show a relationship between the population age structure and economic growth. So historically showing that having more older people is associated with slower growth. There's also an expectation, of course, that older people, of course, will retire in mass, and that this will lead to a shrinking labor force. And so the combination of a less productive labor force and a smaller labor force is expected to slow economic growth, or so people think. And of course, a smaller economy, slower economic growth is bad for tax revenues, where this implies fewer tax revenues will be generated. And since health systems in high-income countries, especially in Europe, are predominantly funded through the public sector, this implies that there will be fewer revenues for health as the population ages. And coupled with expectations, of course, also that older populations are more expensive to provide healthcare for, it sort of gives the impression, if you believe these myths, that the only solution is to cut back on the welfare state, to reduce entitlements, and to shrink the public sector. Now, fortunately, these are myths. There's a lot of nuance to these, and the evidence is not so clear that these are actually true. And so I want to show a little bit of evidence that disputes these myths. So the first is on this relationship between the age of the population and economic growth. As I mentioned, there's a historical correlation between having more older people and slower economic growth. But most people have never looked at whether or not the size of the size of the older population, an older population is, or the relationship, between the size of the older population and GDP growth is moderated by the health of that population. One might expect that an older working age population that's in good health may not have such deleterious effects on the economy. So this figure here, this is a contour plot from a recent study that we've produced that digs into this issue to see, looking back over the past 30 years, across 180 countries, to see whether the health of the older working age population, age 55 to 69, moderates this relationship. And so here in this figure, we have, these are the predicted values from the study. It's called a contour plot. on the x-axis, we have the percent of the population between ages 55 to 69, so the older workforce. On the y-axis, we have the inverse of years lived with disability among people aged 55 to 69, so the health of the older workforce. And of course, because it's the inverse, high up on the y-axis signifies good health and low on the y-axis signifies poor health. And these rainbow colors, these are the predicted real per capita GDP growth. So the dark blues and darker greens imply slower economic growth, whereas the oranges and the yellows imply faster growth. And so what this shows, to understand this figure better, I think it's easier to plot an actual country and a year on this figure. So here we have what many would think is the relationship between an older workforce and the economy. So we have a large older workforce all the way over to the right of the figure. This workforce is in poor health, so to the bottom. And of course, the models based on historical relationships do predict slower economic growth. However, if the older workforce is in good health, we see actually that so that they're higher up on the y-axis, we see actually that the models predict much higher economic growth, so much that having a small older workforce or a large older workforce doesn't really matter as long as they're in good health. So the story here is really, it's not the size of your older labor force that matters for the economy, it's really the health of that older labor force. Another concern, of course, as I mentioned, is that the labor market will shrink as populations age. Of course, people do retire from the formal labor market as they age, but trends in when people have been retiring have changed over time. So this is data from the OECD showing the average age of retirement for men and women. And what you can see is that from 1970 till about 2000, the age that people were retiring was pretty steadily declining. So people were retiring younger and younger. However, over the last 20 years, people are retiring later and later. So there's been a reversal in trends, both for men and women. And what this implies is not necessarily that the labor market will not shrink to some degree, or the formal labor market will not shrink to some degree as populations age, but that it's not going to shrink as much as perhaps it would have 20 years ago if things had stayed the same in terms of the age that people were retiring. So as people leave the labor market later, of course, it keeps the size of the labor market maintained. Of course, we worry about the labor market mostly because labor market is a source of financing for healthcare through social contributions. So social contributions are predominantly financed through labor markets by employers and employees. But what I wanted to show here is that even though, as I mentioned at the beginning, that the health spending is primarily coming from public sources in Europe, the actual source of those revenues varies a lot across countries. So we see there are many countries which have, you can see in orange, this is public spending as a share of current spending on health. So the total public spending on health across countries. You can see there are some countries that rely very heavily on social contributions. So Slovenia, Estonia, Germany, Poland, but by and large, there's a lot more diversity in where the money actually comes from to finance the health system. And of course, these different sources, taxes on income, taxes on property, taxes on goods and services, will be affected to different degrees by population aging, and probably less so than social contributions. Now, of course, I think that this evidence is useful to try and counter these myths that I talked about early on, but it doesn't really give you a sense on a country by country basis in terms of how population aging will affect health financing. And so to give a little bit more insight into this, we've created a simulator, which is called the PASH simulator, Population Aging Financial Sustainability Gap for Health Systems. This is available on the observatory's website, so please check it out. And basically, it's a very simple thought experiment. You can, it asks basically, what if the way that we fund health systems, so where the money comes from, and the way that we spend on health systems, on healthcare, so the way we spend by age, what if these stayed the same forever and only the age mix of the population changed? So it's taking this thought experiment forward and saying, okay, well, what would that actually imply, both for the revenues for health as well as for expenditures? So the way the simulator works, and it's a very simple tool, you choose a country and it gives you its own population by age forecast, and it shows the approach to revenue raising. As a user, you make some assumptions about how health spending will vary by age. Then you see, of course, how the population age mix changes over time will affect revenues and expenditures. And the gap between revenues and expenditures, this is the financial sustainability gap that's attributable to population aging. And then the fun of the simulator is that you can explore policy options and try and fill the gap. So we're going to try and test it out. We're going to randomly pick a country and see what the results hold. I have no idea what country will come up. Let's see. What will it land on? Oh, Slovenia. How interesting. So why is Slovenia an interesting country? Well, it's highly reliant on the labor market to finance the health system, which I showed at the earlier slide. Its population is aging. It's one of the more rapidly aging countries in Europe. And its effective retirement age is younger than the average OECD country. So the age that people are retiring has been increasing, but the average is still, the effective retirement age is still below the average. So we're going to go to the observatory's website. Here we are. We already have Slovenia queued up, which is convenient. So you can explore this as well on the observatory website. So basically, we're going to go through the simulator. So here, we can see the population by age distribution in Slovenia. We see here over the next 50 years or so, it's really this working age population that's going to shrink in size in Slovenia. But the population itself, of course, is expected to shrink as well. And then it will sort of level out after around 2060. If we go and click here on health financing, we get to this page where we make some assumptions about how healthcare is paid for. So the bottom, we can see this is exactly the same as the figure I showed earlier, that bar chart about where the money comes from to pay for healthcare in Slovenia. And so it's mostly paid for by social contributions, about a little more than 90%. The rest is funded through general taxation, which comes from a mix of taxes on goods and services and income taxes. On the health spending side, we don't have the data in the simulator specific to Slovenia, but we can pick one of these illustrative examples of how health spending might vary by age. And these are very, the different choices that you can pick are similar to actual country data. So this blue one here, this light blue one, which I will choose, this is the actual EU average from the European Commission's Aging Working Group. And the patterns make a lot of sense. We see, of course, that babies are very comparatively expensive. And then the per person spending declines and stays pretty flat over the life course until about middle age, and then gradually increases before leveling off among the oldest old. So what the simulator will do is it will combine these different health spending, the health revenues, with the population age mix, and it will produce a forecast of revenues and expenditures. So here we are. So this is the baseline results for Slovenia. So we make an assumption that the base year 2020 was perfectly financed, just to see how things will diverge going forward. So in red, this is health expenditures and how health expenditures in Slovenia are projected to change solely because of the changing age mix. And this is revenues. And what we see is that there's this very clear divergence where by 2050, if Slovenia paid for health in exactly the same way as it does now, and if per person spending by age stayed exactly the same, we would expect that the financing gap would be about 2% of GDP, so a fairly substantial financing gap. And about half of that financing gap, as we can see here, is driven by reduced revenues. So the question really is whether Slovenia can improve its health system financial sustainability, and whether there might be lessons in thinking through the issues for Slovenia that will be applicable to other countries. So Charles, I'll hand it back to you to see if we can find somebody from Slovenia that can tell us a little bit more about what's going on there.
Thank you, John. And by coincidence, we do have a speaker from Slovenia who has possibility of explaining what are the options for that country. So over to you, Vesna. If you could give us a policymaker's perspective from the context of Slovenia. Thank you.
Hi, I'm so glad we won on PERS simulator lottery. It is a frustration for us. Yes, our population is aging. I have here some slides pre-prepared because I am very optimistic. So I said most probably it will be Slovenia chosen for this simulator and to see how we will be doing. So please, first slide to share some information with you. Nice. So here you see the data that me as policymaker, and I have been at the Ministry of Health for more than 25 years now, working with different ministers, decision makers. We do have information which is worrying. And for us policymakers, it's really important that we can rely on policy briefs, so brief information that is available to us and we can quickly see what the situation is. And if we look on some policy papers, and they are mentioned here, we can see that what John has shared with you is actually truth, and also our statistical office is forecasting that in 2100 we'll have 31% of population over 65. Here we also understand that, you know, we have a problem with low fertility rate, and this most probably will not change. And life expectancy at birth is rising, which is great for us, but this adds to the problem anyway. Also, we are not very lucky with migrants. It is the language question also. Not so many people immigrate to Slovenia, so we cannot count on this actually. And what is even more worrying is that people aging will also not be, as it is at the moment, so healthy if we don't do something. After 65, more than half of life lived is spent with health issues, disabilities in Slovenia. So this is additional problem that we have to consider. Next slide, please. Well, is there anything else to worry about? Yes, it is. This is not going to be better if we don't do something about it, because here we can see that the risk factors for chronic diseases, we have done a lot, but mostly in grown-ups. So we have actually reduced quite substantially smoking rates in adults, but we are not doing so well in smoking among children. Even worse, it's with binge drinking and obesity in children. We have recently leveled it up, but during COVID, we can again observe that, you know, obesity in children is actually rising. So there are many issues we are confronting them that will actually have an impact on the future of our working population and the aging also. Please, next. So this is not all. We also have barriers in access to healthcare and preventive services for the most vulnerable. We are trying to deal with this, but this is still there. And another thing that is worrying, next one, is also that there is higher prevalence of risk factors among disadvantaged groups, which contributes to inequalities in health. So these are all the factors that for us policymakers are worrying, and we have this urge to do something about it. Next slide, please. So we in Slovenia are very fond of our health system, I can say. In particular so because high degree of financial protection is assured in our system, and catastrophic health expenditure in households are very rare. It's 1% of population was in danger of catastrophic health expenditures in 2015. Reported unmet needs among the lowest in EU. This is also a great success. So we would like to keep our system being as successful. But of course, as it was said by John, public share of health spending is, yes, increasing, but majority of population also had complementary voluntary insurance. So population is really well covered by health insurance. but healthcare funding is highly cyclical, and this is a problem as it relies almost exclusively on social health insurance contributions to our national health fund. For us, and I am coming from public health, it's also worrying that we do invest only 3% of total spending to preventive services, and spending on long-term care accounts for a very limited share, 9.8%, and is below EU average. Next slide, please. As I said before, we are aware of a problem, and we have in 2015 embarked on a thorough analysis of health system, because we wanted to see in every detail how we are performing and where our opportunities for change. And from that analysis that was performed by Observatory on Health Systems and WHO, we could clearly see that what is needed is diversification of funding resources, and that we would also need to raise additional funding for health and healthcare. Investments in primary healthcare strengthening have already been implemented. I mean, we have already used substantial funding from EU cohesion funds to introduce health promotion centers and mental health centers, which are established within health centers at community level. So there are multi-professional teams working there, and there is actually integration of primary health and public health services going on. Life course approach is used, and the focus is on most vulnerable. So this is one thing that has been done to actually address the problems that I mentioned before. And introduction of an additional registered nurse was also very important. This was done in 2011, and the nurse was meant to monitor chronic patients, navigate patients with chronic diseases through the health system, and to perform also individual preventive services. Very recently, adoption of Long-Term Care Act has been successful in the parliament. It was now in 2021, late in December. This was a great success because we spent quite some time at a political level to agree upon how we want to have Long-Term Care Act, but we didn't yet agree completely on how to fund long-term care. The available resources will be used, but deciding on the new resources will be in 2025. Next one, please. So, financial sustainability of health system in an aging population. This is a serious question. And it's not just a question of, additional money, because what we are after is how to use money to fund accessible and efficient healthcare, how to keep people healthy, how to address inequities in health, introduce new technologies also, respond to health crisis and respond to economic crisis, and so much, much more. And here, I'm looking really forward to what John will have to share with me and with all of us. What are the appropriate financial or other mechanisms that Slovenia should use? Is this additional sources of funding? Is it, of course, we said it is diversification of funding, but how? And also increasing retirement age is an option. Is it appropriate one? And if so, how we are going to keep people healthy and fit and motivated to be able to work longer. So now, John, here is a challenge for you. I hope you will be able to respond me and give us in Slovenia some advice how to handle this situation.
Thank you very much, Vesna. That, I think, gives us some very good pointers to where the challenges lie. As John was saying, it's very important to understand that it is as much the health of the elderly population as the size of the elderly population that's going to be important, but also you're drawing attention to the particular issues around the financing of the health system and long-term care. And as a result of that, we need to look very carefully at what we can do within the existing policy measures that are available to us. But one of the other issues that comes up very much in this is the question of who can work and who will work in older age. And the next speaker will be Mauricio Avendano from the University of Lausanne, who has done significant work around the issues of who is capable of working in older age and how perhaps we can encourage people to work into older age if this is going to be useful for the sustainability of the health system finance. So over to you now, Mauricio.
Thank you very much, Charles, and thank you, Vesna and John, for this really exciting discussion. I'm very pleased to be here, and what I want to discuss today very briefly is just to try to address this very important question of how longer working, so extending the time that we spend at work, may contribute to the financing of healthcare for an aging population. Much of what I'm going to tell you comes from one policy brief from the Economics of Healthy and Active Aging series that you see here and you find at the WHO website. So let me just go back to the initial question. Why do we think that working longer is essential for the sustainability of the welfare state? Why is this question so often raised? This graph shows you a simple illustration of that. The blue line shows you the life expectancy in different countries, while the yellow kind of line and the orange line shows you the effective age of retirement, the age at which, on average, the population retire. And essentially what you see in every of these countries is that despite the fact that in recent years there's been a bit of an uptake, an increase in the age at which we retire, so we work longer, overall there's been an increasing gap between life expectancy and the effective age of retirement. That means that as we are living longer, we are not necessarily working longer. And this gap in some countries is increasing, in others will probably remain quite stable, but it's unlikely to shrink. And this poses a challenge to the sustainability of several components of the welfare state. The main one in discussion has been the pension system, obviously, but what we're saying here is that this may also have implications for the revenues of the health system. The more we have populations at work, the more we're able to collect revenues, particularly in countries where social contribution and taxes and income represent an important source of financing. So the next questions that you may ask is, okay, are we in good enough health? Are we in good health to actually work longer? And this is a very difficult question to answer. But I wanted to share with you some results from a study a couple of years ago from Coyle, Michigan and Weiss, who tried to basically ask the question, how much people actually work in older age, and what is the additional work capacity that people might still be able to work? And they looked at this question by basically comparing how much people work today with how much they worked in the past relative to the age that they have. And essentially what they conclude, which is illustrated in this graph, is that actually there is much additional work capacity in older people in many of the countries of the OECD. So just to take an example, in Japan, around 50% of the population of males at ages 65 to 69 is in employment, and they conclude that there is an additional 40% of capacity that is possible in this country. In other countries, European countries, basically, if you like, the additional work capacity or the unused work capacity is much, much larger, 77% in the Netherlands, as most people retire, not because they have a health problem, but because basically they reach the statutory age of retirement. So essentially, this is basically trying to tell us that there is an additional work capacity. And in response to this, already, for many years, countries have been trying to extend the retirement age. This shows you a summary of those changes. So, for example, in, say, Belgium, a female would expect to retire at age 62 in 2002, and this is now 65 in recent years, and has continued to increase with subsequent reforms. So there's really this rhetoric that we need to work longer and that the response needs to be to increase the retirement age. However, the main point that I want to make here is that there are a couple of problems with this approach, and that we might take especially a different approach that also consider the need for further investment in the health system. Now, the main two problems that I want to highlight is the fact that these calculations that we see here, looking at the additional work capacity, they often do not take into account the role of mental health. Mental health is one of the main reasons why people go into disability benefits, and also one of the main reasons why people bridge into early retirement. However, in these calculations here, we're not considering the role of mental health, and mental health in many countries is really one of the main reasons why people leave work. work. So really what we need on the one hand is to think about conditions of mental health that might be really relevant to maintain people in the labor market. Now, the second point that I want to make is that although we may agree that working longer makes sense from a financial sustainability point of view, actually the reforms that have increased retirement age may have their own effects on people's health. Here I'm showing you the results of a study that we did in the UK looking at the impact of the increase in the state pension age, which is illustrated in this graph in the top, where you see that the official state pension age at which women can claim benefits changed from age 60 to age 65 for cohorts subsequently who were born in a very similar year. So this is a really, really large increase in the state pension age. And what we showed is that this really massive increase had a negative impact on the mental health. For example, depressive symptoms here, an increase of 4 percentage points in depressive symptoms and a decline in the overall mental health. And particularly for workers in jobs with high demands and very low control, we see a very negative effect also on physical health. So increasing the age of retirement by legislation might not necessarily be at least not the only way by which we encourage or may encourage to have a population that works longer, but that also maintains good health. So this leads me to the final slide, which you can find these details further in the policy brief, but we're really here sort of promoting that a different approach is needed to get people to work longer, and 3 aspects are important. One of them is that we need to develop policies to promote a more supportive work environment. The second one, we need to invest in mental health, and the third one, we need to strengthen our social protection system, particularly the disability insurance system. To promote supportive work environments, there is a considerable body of research showing that interventions in the workplace by employers, but also mandated by government policy, that are multidisciplinary, that involve things like behavioral training, workplace modifications, and the adaptation of the workplace are really essential strategies to actually maintain all the people in the labor force, particularly musculoskeletal disorders and mental health interventions are important. And finally, the combination and integration of disability insurance with incentives and support for people to continue to work, but at the same time, not losing benefits from disability insurance. So these are just some examples just to open the discussion as to strategies by which we might increase labor force participation while at the same time maintaining a healthy population. Thank you very much, Charles, and I'll give back the microphone to you.
Thanks very much, Maurizio. And I think what you've done is to provide us with a lot of very important pointers to what the directions of policy development might be, particularly around the quality of the work environment for older people and how we might be able to improve the work experience, since there is this risk of a very negative effect if people are required to continue to work in jobs that give them no satisfaction and no control. So perhaps we can come back to that in the discussion and think a little bit more about that. A second direction, though, of policy development that has come up in these discussions is the question of the sustainability of public revenues and tax revenues. And one of the possible directions of travel here will be to improve the stability of tax revenues by changing the mix. And we're very lucky to have Trin Habrich from the WHO office in Barcelona, who's going to be talking about diversification of tax revenues. So over to you, Trin.
Thank you very much, Charles. And then let me share my slides, hopefully successful. If not, then just let me know. What I'd really like to show you as a first slide is the figure of countries where social health insurance scheme is more than half of overall public spending on health. And then, of course, you have to keep in mind that this is pre-pandemic data from 2019. But what you can see is that it confirms what John showed us just a few moments ago, that in 2019, government budget transfers were an important supplement to social health insurance contributions in many countries. So it's for example, if we look high-income countries, then even in some countries, it forms more than 1/3 of overall revenues. Like if we look at France, Greece, Hungary. But you can see that in some countries, like Slovenia, it's only a tiny part of overall social health insurance scheme revenues. And it has been also historically very low in Estonia. And actually, this leads me to the recent reform in Estonia, which could be inspiring for Vesna, because historically and in the past, Estonia has been seen also a country which is relying only on contributions to finance health insurance system, and there was kind of no way out of that. But there were several studies, also some conducted by the WHO, and all of them recommended that Estonia should consider very seriously diversifying the revenue base of health insurance system. And why it's Estonian example is especially kind of relevant during this webinar is because aging argument was one of the key arguments what was used during the policy discussions. But not only, actually, if you look also the design of the proposed budget transfer to the social health insurance scheme, that was also building on aging argument. And as a result, starting from 2018, the health insurance fund receives additional budget transfers from the state budget on behalf of non-working pensioners. And non-working because the argument was that working pensioners are already contributing. So we really have to focus on non-working part of pensioners. And then it is this transfer is calculated as a percentage of state guaranteed pension. Initially in 2018 it was 7%, and it increased up to 13%, which happened this year. And 13% because it is exactly the same percentage what people pay from their salaries as well as a health insurance contribution. And on this slide, you can see this figure. You can see this transfer as a dark gray part of health insurance funds revenues. And you can see it's increasing over time. And then of course, because of COVID, it's a situation changed. You can see additional budget transfers to which are COVID related, which is a red part of these bars. And then starting from last year, actually there was additional budget transfer, which is light gray, which is not directly linked to COVID response, but it is more addressing like improving access to care. And what happened with health insurance fund revenues, if you look this green line, you see that it was, if you look health insurance fund revenues, then in 2017, 98% of health insurance fund revenues were coming from contributions, and it dropped to 77% in 2021. Yes, partly because of COVID, but not only. And of course, time will show if these additional budget transfers all will be sustained. But of course, it's also kind of difficult to take money away and just to eliminate revenues without addressing them structural issues. But let me now go to my final slides and final thoughts. What countries can do, including Slovenia, find the money to fund the healthcare for an aging population. And then, of course, the first thought is that in many countries, health sector's priority could be increased in the government's budget further. Before pandemic, there were large variations, even among high-income countries in Euro region. For example, in Germany, in the UK, health sector received about 20% of overall government's budget, but in some countries it was less than 10%, for example, in Cyprus, Hungary, Greece. Of course, as a result of pandemic, countries increased health budget, but there are good reasons to sustain that increased funding in the future as well. Second message, of course, is related to diversification of the revenue base. Don't keep all your eggs into one basket. And that relates very much to the Estonian example I just showed. And there are, in addition to aging, of course, there are many other good arguments in supporting this diversification. Third message is related to the contribution design, which in some countries is highly nuanced and complex. And it makes sense to review its design on a regular basis to assure that it still serves policy objectives. For example, does it take into account the wage-related or wage-related income, or also other type of income? Because we do know that the role of non-wage related income is increasing in many countries in our region. And then fourth thought is related to long-term care insurance, as countries see that as one option to address the funding gap. But in some countries, social sector is not so close to the health sector as it could be, which may mean that the design of the long-term care insurance is discussed without engaging health sector. That be, of course, very unfortunate, as we do have a lot of evidence to share on what works and what does not work so well. For example, public-private insurance, implications of linking payment of contributions to entitlements, and so on. These are all thoughts from my end, and then back to you, Charles. Thank you.
Thank you very much then, Trin, that's very helpful. Now, this is a stage in the seminar when we can start to discuss the feedback from the audience here. And Erica has been doing some reviewing of the questions that have come up. Perhaps you'd like to start us off then.
Yes, it's been a very busy chat box, some really interesting things. To kick off with, there's been quite a lot of questions around what do we mean by health expenditure in this context. So are some social care costs included, long-term care costs, or are we strictly talking about sort of like hospital-based care? So that would be one sort of group of questions. What's included and what's excluded from this expenditure? But then building on that, is there some kind of optimal blend of financing sources for health and social care? And are there any particular innovations in this field that we should be looking at? Because this is very much, looking to the future. And then looking at sort of working at older ages, how ready are employers to make workplace adaptations for older people in Europe? And what might change this? What about workforce shortages? Is that something that's on the horizon? Or indeed youth unemployment, if we're talking about retiring at older ages? And how does the whole gig economy and precarity fit in with this discussion of the labour force? So some quite big meaty issues coming out. But yes, thank you very much.
Thanks. Well, perhaps if we start with the what do we mean by expenditures? John, perhaps you'd like just to do some clarification, and then I'll explain.
Yeah, sure. So in the simulator, when we refer to health spending, we're primarily talking about healthcare, not social care or long-term care. And the reason is because primarily it's because of where the money comes from. So in healthcare, we have a pretty good information on how the health system is financed. We know the public-private breakdown. We know how much of it comes from social contributions. We can make a guess at what the rest of the general taxation looks like based on how the overall public sector is financed in a country. Whereas there's much less information about social care and long-term care. And also these are oftentimes financed in a very different way from the way healthcare is financed. So we could do a very similar exercise to the simulator, looking at long-term care, especially in a country where health and social care are funded in a single pool through the same mechanisms. But because in most countries they're financed differently, we can't really look at them together in a very easy way. That being said, obviously, I know there are a lot of concerns about long-term care changing the story, and we will talk about this next week when we focus our attention on expenditures. So this week we're talking about revenues, but next week we'll talk about expenditures and healthy aging and end-of-life care and things like that. But I do just want to point out that long-term care, even though there are expectations that having a doubling of the population over age 85, let's say, will lead to a near doubling or in terms of long-term care needs. We're talking about very low baselines in terms of actual public spending. So in most countries in Europe, public spending on long-term care is still only 1% of GDP to 2% of GDP. So a doubling of that is not a huge amount of, it's a huge amount of money to me, but it's not a huge amount of money in terms of the public sector. And I think the questions we need to be asking, and the questions that I think we're trying to ask through this simulator and also through the session is this is really about, it's a choice about how do we pay for this, not whether we can afford to pay for it. And so when we're talking about long-term care, yeah, doubling from 1% of GDP to 2% of GDP is a lot of money, but it's much more how would we pay for it? Where would that money come from? Because obviously health spending is already quite a large share of the public sector. Maybe I'll stop there for that.
Thanks, question. John. Perhaps then if we just move on to this question of sort of the optimal blend. Trin, you were talking about the diversification of financing. Is there an optimal blend, or is it something that each country should be looking at and in terms of its own traditions and its own mechanisms?
Excellent question, and thank you, Charles. It would be great if, of course, there would be optimal blend, and then to use that as a very a strong recommendation to countries. But every country has its own past and history, and starting points are very much different. So it's you are very right when Charles you mentioned that it is really depending on the country context. It depends what has been there in place before, and of course what is politically feasible as well. So it's because it's usually it's not only a technocratic exercise. It's highly political decision as well. But what we do see is where we can be it's very strong in our recommendation as a WHO is that we can recommend also countries which historically have been basing on employment-related taxes, that increasing funding from as a budget transfers from general budget is definitely the very much highly recommended way forward. There we can be strong, as well as those countries. And not really, we are not here talking about high-income European Union countries, but countries which in our WHO European region are just designing their health financing big reforms. There we do recommend that instead of starting to introduce contribution-based health financing system, you rather opt for a system which is fully funded from general taxes.
Thanks, Trin. I'm always reminded, there was one of the questions came up, was there any experience of innovations in the way that financing is done? The only thing I would always want to warn is that ultimately all the money comes from us. There is no Santa Claus. I'm sorry if anyone is confused at this time of the year, but there is no Santa Claus, that all the monies that go into the health system must ultimately come from people in the population. The question is only how it comes and how efficiently it comes, not whether it comes from the population. So I think we've got to be a little careful. If anyone has a good idea that makes it painless for people to pay for healthcare, I think they should get the Nobel Prize, because certainly there's no evidence that there are painless ways of doing that. The question is, what are the most efficient ways of doing it that spread the burden in a fair and equitable way and raise the revenues that are needed in order to finance the system? But the other important point that's been brought up was around working at older ages and how employers might improve their provision for older workers, and also some questions around the trade-off between older workers and youth employment. So perhaps, Mauricio, you could just give us some thoughts on what are the key things that employers could do and what should they be doing to get this part of the labour force usefully employed, but also how does that relate to youth unemployment?
Thank you very much, Charles. That's a really, really good question. I think, as I was saying also in the chat, I think the first element that it's important is really legislation and really creating policies that generate incentives for employers to actually make adaptations and to invest in the health of older workers. And I would say that many of the adaptations that are needed are actually beneficial for the well-being of all workers. So this doesn't need to be something that it's only targeted to actually older workers. And what we're talking about here is really policies that enable work flexibility, for example, in schedules, the ability to do part-time work, interventions to improve the well-being of workers, and overall what we call kind of increasing workability, which is creating this environment that increases people's ability to work. It's a really interesting question around the relationships in youth employment and older age employment. In economics, people wonder about this question for a long time, and it's considered one of these so-called fallacies, whereby actually the employment of older people doesn't seem to have a causal effect on the employment of younger people. Now, this is controversial, but most of the studies show that, for example, countries where there is a high employment rate among older workers have also a high employment rate among younger workers. So, it's a controversial issue, but it's not per se the issue that the fact that we increase the supply of labor among older workers will have an impact on younger workers for many different reasons. That's not the case. These seem to be two things that we can separately promote without necessarily hurting each other groups. So I'll keep it there, Charles. Happy to discuss further.
Thanks very much. As the only panelist over 65, I'm looking forward to all these innovations to make my life better as an older worker. So anyway, the question then of how we ensure greater employment, better ways of ensuring that the revenues are raised in a stable way. Maybe we could go back to Vesna now and think how much of what we've been discussing today could be applied in the case of Slovenia. What have we said that may make your life a little easier? And do you have any other ideas that might be brought onto the table for discussion?
Well, thank you very much. I think there were a lot of ideas. Especially interesting was the Estonian example that, of course, could be used. I think that during the COVID, actually, also in my country, we have invested a lot of the budget money into health sector, and I think health insurance fund could never cope with the COVID if that wouldn't be done. So this kind of crisis demonstrate how important it is, and also that it can be done. This is one thing we have learned. And there was a question that why don't we talk so much about the healthy aging and primary prevention? I think I did mention in my presentation that actually we did base our policies first on this, because we wanted to assure that our population, when aging, will be as healthy as possible. And by this, we intended, of course, to reduce the impact on the health systems of the growing non-communicable diseases that go with aging. Also, I would say that there is no one answer to all these questions. It's, I think, a combination of everything that will finally work. These kind of tools are very helpful to persuade politicians to adopt a little bit more easily very difficult decisions, because this is also, I think, a problem that we spend ages to adopt appropriate decisions and we are lagging behind. And this is also probably because it's so difficult to come with appropriate arguments to the political level that, of course, I wouldn't underestimate politicians, but this they have to think of so many things. And for them, it has to be an easy solution, because their mandate is very short and they have to know exactly what to do and why. And these kind of problems, of course, can be better solved if we have this kind of PER simulator type things available. This is a kind of innovation that is also useful, because we should not think of innovation in the health sector only in medicine, pharmaceuticals, but also in how systems are organized, financed, and also how we support politicians. Also here we have to be very innovative. And I finish here. Thank you.
Thanks, Vesna. Erica, are there any other pressing questions that have come through on the chat that you think we should be giving some final airing to?
I think, yes, there are just sort of like two sort of littler questions. One is, why are we focusing so much on public financing for care instead of private financing when it is actually dominant in many countries? And then what about retired people? How do they contribute to GDP if they're not working? And also we need to reflect on the wider contributions they might make through unpaid labour. A big shout out to my dad who does childcare at age 85. So, yeah.
Well, perhaps, John, you could say a couple of things on this before we finish.
Yeah, no, thank you. So I think on the why we're only looking at public spending, the reason is that you can sort of assume that if everything were to stay the same in terms of the benefits package and population coverage, that the financing gap would be made up, would be financed through private spending. So the idea would be that, of course, that if you're unable to finance your expenditures through your public revenues, the difference must come from somewhere. So we don't include private spending because of the sort of implicit assumption that, well, this gap, if we don't sort it out through policy intervention on the public side, then it obviously needs to be filled in some other way, and that would be through private finance. So that's why we only look at the public sector. And I mean, of course, we think that the public sector is the preferred place for the sake of equity and to be financing the health system.
And the other point that was being raised there was around how do older people contribute? Erica has already described one way in which older people contribute through voluntary and unpaid work. And I think this is an area where we need to have a very much clearer understanding of the huge contributions that are potentially made by older people, partly in areas like childcare, which allow younger people to be in the formal employed sector more fully, but also the way in which they provide directly some of the services that would otherwise be paid for. And I think we can discuss this at a greater length later on. But perhaps this is the moment to start looking forward to our next set of seminars. So before we do that, I'd just like to thank the panel very much for the excellent contributions and for the excellent questions that have come through the chat, and just something for you to look forward to. We have the next two webinars in the Economics of Aging series. The next one is, can the costs of caring for an aging population be controlled? This is looking at ways in which we meet the needs of older people without necessarily having uncontrollable costs. And the third one is the politics of aging creating conflict between the generations? Is this conflict between generations, or are there ways in which we can all benefit from good policy making around aging and healthy aging? So thanks again to our panel, and thanks to all of you who have joined us for this, and goodbye for now.